Hello, good day, and welcome back to the Med Guru CDB YouTube channel. For this short video, we're going to go over some surgery pearls regarding the chapter on wound healing and repair. These are the two major references I'm using for this video. It's Schwartz Principles of Surgery, both the 10th edition, actually the 9th edition also, as well as the ABSITE board review. Now, let's start the ball rolling. There are two classifications of your surgical wounds. We have the acute wounds and we have the chronic wounds. So for the classification of wounds, we have acute, then we have your chronic wounds. Now, verbatim definition, as for the acute wounds, these are the type of wounds that normally proceed through an orderly and timely reparative process that would result into sustained restoration of anatomic and functional integrity. So for the acute wounds, please take note, there's an orderly and timely process of repair that brings back or restores the anatomic and functional integrity. As for the chronic wounds, the major difference between the chronic and the acute wounds is in the chronic wounds, this is a repair process without establishing sustained anatomic and functional result. So the major difference between acute and chronic wounds would be establishing a sustained anatomic and functional result or functional integrity. So acute is able to restore, however, the chronic wounds, there is no establishment of sustained anatomic and functional integrity. Now, three types of wound closure. We have primary intention, secondary, and tertiary intention. So primary, secondary, and tertiary intention. Now let's go over the definitions. So this is primary intention. This is an illustration lifted from your textbook. So here you see the suture. Secondary intention, then we have tertiary intention. So let's go to the definitions. Now for primary closure, this is characterized by the use of sutures, staples, or tape. So there's approximation of the acutely disrupted tissue, which is the wound, with the use of either sutures, staples, or tape. And please take note that during the process of primary closure, the role of collagen as well as other matrix proteins is very significant. So the synthesis, the deposition, as well as the cross-linking of collagen and other matrix proteins would provide the tissue with both strength and integrity. So there are conditions that affect the synthesis, deposition, and cross-linking of collagen that would affect wound healing. And the first would be your vitamin C deficiency or your scurvy, because vitamin C or ascorbic acid is required for the cross-linking of collagen. There are also some genetic conditions which affects collagen synthesis, such as Marfan syndrome and Ehlers-Danlos syndrome. So they also present with poor wound healing or even easy bruisability. Now for your delayed primary closure, so for delayed primary closure, the approximation of the wound is delayed for several days. So your keyword here is delayed. So this would be several days. So there's no use of your sutures here. So approximation of the wound is delayed for several days, and these would be the indications where delayed primary closure is utilized. So number one, when you have a wound with significant bacterial contamination, a wound with the presence of foreign bodies, or a wound with extensive tissue trauma. So let's repeat that. Delayed primary closure is indicated to prevent infection in wounds with significant bacterial contamination, foreign bodies, or extensive tissue trauma. Next is spontaneous or secondary wound closure. This is defined or characterized as the margins of the open wound moving together by the biologic process of contraction. So the contraction we're referring here is wound contraction. So spontaneous or secondary wound closure, the margins of the open wound move together by the biologic process of contraction. Now, there are three mechanisms in wound healing. Number one is epithelialization. Second is wound contraction. Third is connective tissue matrix deposition. So the three major mechanisms in wound healing: epithelialization, wound contraction, and lastly, connective tissue matrix deposition. Now, what is epithelialization? This is defined as the process by which the keratinocytes migrate and divide to resurface the skin or the mucosa. The process by which the keratinocytes will migrate and divide to resurface the skin or mucosa. So if you see the epidermis here, so there's the epidermis. This is your keratinocytes here. There. So the keratinocytes are the cells responsible for epithelialization. Now, don't forget, vitamin A plays an important role in epithelialization. So vitamin A. Now, what is contraction? This is the mechanism whereby there's a spontaneous closure of full thickness skin wounds or constriction of tubular organs. So in the case of wound healing, this is the mechanism whereby there's spontaneous closure of full thickness skin wounds. And the third phase, which is the connective tissue matrix deposition, this is where the fibroblasts play a very important role. So your fibroblasts. So these are the cells that are recruited to the site of injury, and it is the fibroblast that will produce your new connective tissue matrix. So the fibroblasts are recruited to the site of injury and produce a new connective tissue matrix. So let's repeat the three phases of wound healing: epithelialization, contraction, and connective tissue matrix deposition. So here we have the phases of wound healing: hemostasis or coagulation, inflammation, proliferation or fibroplasia, and lastly, maturation and remodeling. So the phases of wound healing: hemostasis, coagulation, inflammation, proliferation or fibroplasia, and maturation and remodeling. Now let's dissect these phases. Let's start with hemostasis and inflammation. Now, during the first 24 to 48 hours, the polymorphonuclears, or the neutrophils, are the first infiltrating cells to enter the wound site. The polymorphonuclears, or the neutrophils, are the first infiltrating cells which will enter the site of the wound. And this usually occurs within the first 24 to 48 hours. During this phase of hemostasis and inflammation, vasoconstriction occurs, and this occurs after injury. And there's the release of vasoactive substances, which initiates diapedesis. The platelets will now form a clot. So you now have a platelet plug. And the clotting factors will now release fibrin. So again, during hemostasis and inflammation, during this phase, the polymorphonuclears are the first infiltrating cells that will infiltrate the site of injury. There's vasoconstriction, the release of vasoactive substances, which initiates the diapedesis, the formation of the platelet plug or the clot, then the release of fibrin. Now, this is lifted from your Schwartz absite. So we have the epidermis here, the dermis below. So here's the disrupted blood vessel. There. Your platelets now come in, forms a plug. Here's your RBCs. Clotting factors will now release your fibrin, and you will now have a fibrin clot. Now, next phase is your proliferation. Now, during this phase, this is when the continuity of the tissue is reestablished. So tissue continuity is reestablished. This is also when the fibroblasts and the endothelial cells will arrive. So during the phase of proliferation, this involves the arrival of the fibroblasts as well as your endothelial cells. Now here is now the scab that you have, the fibroblasts, endothelial cells, and the macrophages now come in. So always remember, during acute inflammation, it's your polymorphonuclears. And as the inflammation progresses, it's when the macrophages come in. Now, I want everyone to memorize this by heart. A specific fibroblast known as your myofibroblasts. So this is postulated as being the major cell responsible for wound contraction. So memorize, the myofibroblast is the major cell responsible for wound contraction. So it starts off with a fibroblast, differentiating into a myofibroblast until it becomes a differentiated myofibroblast. Now, memorize this. This is lifted from your textbook. The peak number of fibroblasts in a healing wound occurs 6 days after injury. The peak number of fibroblasts in a healing wound occurs 6 days after injury. And take note of this. The primary function of the macrophages is the activation of cell proliferation. The primary function of your macrophages is the activation of cell proliferation. Now, please remember, the macrophages usually come in from the 4th day after injury until the wound is completely healed. So the macrophages come in the 4th day after injury until the wound is completely healed. And the primary function of your macrophages is the activation of cell proliferation. Now here, you have your blood vessels here. This is the dermis. The yellow, that's the dermis. This is your epidermis. So there's now formation of granulation tissue. You have your fibroblasts, and you have your fibrin clot here. Now, this is also lifted from your textbook, some pearls I want everyone to bring with them, not only for examination purposes, but also for clinical practice. So vitamin A, what is the role of vitamin A? It can stimulate epithelialization of a wound that was affected by steroid-delayed healing. Now, steroids are anti-inflammatory, but steroids to some extent would affect wound healing. The role of vitamin A is to stimulate epithelialization, particularly if a wound that was affected by steroid-delayed healing. Now, the major effect of steroids is it inhibits the inflammatory phase of wound healing. The major effect of steroids is it inhibits the inflammatory phase of wound healing. Now, which phase of healing is most affected by corticosteroids? We mentioned the inflammatory phase, and this would be the initial phase of cell migration as well as angiogenesis or the formation of new blood vessels. So which phase of healing is most affected by corticosteroids? It's the initial phase of cell migration and angiogenesis. Now, another pearl I want you to know. This is your dilute sodium hypochlorite. This is known as your Dakin solution. Now, what is your Dakin solution? This is a dilute sodium hypochlorite or bleach, which is used for the treatment of contaminated wounds. So Dakin solution is a dilute sodium hypochlorite solution which is used in the management of contaminated wounds. Now, what amino acid is most active in terms of wound hypoplasia? That would be arginine. And please remember this, basic biochemistry pearl. Don't forget arginine is also the amino acid precursor of nitric oxide. So the amino acid that is most active in terms of wound fibroplasia is arginine. And arginine is the amino acid precursor of your nitric oxide. And don't forget, deficiency of vitamin C or ascorbic acid leads to a failure of collagen synthesis as well as cross-linking. So this would explain why patients with scurvy or vitamin C deficiency present with poor wound healing. Now let's wind up with the last pearls. So nutrition. So always remember, collagen synthesis is affected by the nutritional status. So if the caloric protein intake stops for 24 hours, then collagen synthesis ceases. Let me repeat this. If the caloric protein intake stops for 24 hours, then collagen synthesis ceases. And the lack of ascorbic acid or vitamin C is the most common cause of wound healing deficiency. The lack of ascorbic acid is the most common cause of wound healing deficiency. Now, what about the role of the mineral zinc? Now, zinc plays a role in proper wound healing. Now here, if you look at this illustration, the role of zinc in wound healing. Number one, zinc initiates the proliferation and migration of your keratinocytes. So if you remember, the keratinocytes play a very important role in epithelialization. So zinc initiates the proliferation and migration of your keratinocytes. It also plays a role in autolytic debridement. It also has an anti-inflammatory and antimicrobial role. And lastly, it also initiates fibroblast proliferation as well as collagen synthesis. So the role of zinc in wound healing: proliferation and migration of keratinocytes, autolytic debridement, anti-inflammatory and antimicrobial properties, and fibroblast proliferation and collagen synthesis. Now please memorize this by heart. Acrodermatitis enteropathica, or AE, this is a congenital zinc deficiency. So they would present with poor wound healing. They'll present with dermatitis, and they would present with recurrent skin infections. So acrodermatitis enteropathica is congenital zinc deficiency. Now, please bring this pearl with you. What type of collagen is associated with a healing wound, a granuloma, or your reticular fibers? This is type 3 collagen. Now, I hope you take time to look at our other supplemental video on collagen synthesis and collagen disorders. This would be a perfect supplement for this surgery topic on wound healing and repair. So again, do take time to review the video on collagen synthesis and collagen disorders. So type 3 collagen is associated with a healing wound, your tissue granuloma, and your reticular fibers. Now, the role of your TGF-beta. What important cytokine mediator in wound healing plays a role by mediating angiogenesis? So the important cytokine mediator in wound healing, which plays a role in mediating angiogenesis, this is your TGF-B or your TGF-beta. So TGF stands for Transforming Growth Factor. Your Transforming Growth Factor plays a role in mediating angiogenesis. Now, please don't forget this. Your epithelialization, we mentioned the word renewal. So this is the process of epithelial renewal after injury. And in epithelialization, the keratinocytes play an important role. And please memorize these magic numbers. Epithelialization of a sutured wound usually occurs 24 to 48 hours. So epithelialization of a sutured wound usually occurs 24 to 48 hours. And re-epithelialization is complete in less than 48 hours in the case of approximated incised wounds. So for as long as the wound is incised, it's well approximated, it's not large, there's no nutritional deficiencies, re-epithelialization should be complete in less than 48 hours. And winding down, we have two terms you have to be familiar with: the keloid and the hypertrophic scar. So a hypertrophic scar is a scar which is characterized by staying within the confines of the original wound. So a hypertrophic scar is a scar that stays within the confines of the original wound. Now, once this scar extends beyond the border of the original keloid, of the original wound, then this is now known as a keloid. So major difference between hypertrophic scar and keloid: hypertrophic stays within the confines of the original wound, while the keloid extends beyond the borders of the original wound. Now, some pearls again. Mechanical strength or tensile strength of the scar never achieves that of the uninjured tissue. So mechanical or tensile strength of the scar never achieves that of uninjured tissue. So the tensile strength or the mechanical strength of a scar will never achieve the mechanical strength of an uninjured tissue. So a scar will always be a scar. Now, chronic wounds, wounds that have not healed in 3 months. We also mentioned the chronic wounds earlier as wounds wherein there is no restoration or sustaining of anatomic and functional integrity. So I'd like to end up with this. A chronic wound, an ulcer associated with your chronic wound. This is your MARJOLIN'S ulcer. Please make sure you bring this to the exams. Now, MARJOLIN'S ulcers are associated with chronic wounds, and the important pearl to bring with you is MARJOLIN'S ulcers can be precursors for carcinoma, specifically squamous cell carcinoma. Okay, so I hope you learned some important pearls regarding the surgery topic on wound healing and repair. This actually also overlaps with the topic of wound healing and repair in pathology as well as medicine. So this is Doc Toom saying happy studying. God bless. Salamat. And thank you for watching the MedGuru CDB YouTube channel. Please share with your friends. Repeat the videos as many times as you want. Subscribe now to our channel. And please look forward to more videos that will be uploaded. This is Doc Toom saying goodbye and thank you.